just pretend that was a practice run. So people online couldn't hear that. So I'll quickly just recap. So today's going to be a clinician's guide to artificial intelligence in healthcare, very much from a clinician's point of view rather than from the technologist or a computing point of view. So as I said, we've had a fascination with AI for a long time, both in our literature and our movies and popular culture, because our machines are useful decision-making tools. They're a font of knowledge, and they're also free from the frailties of human existence. So they're very reliable. When we look at artificial intelligence, we need to review what human intelligence is. It's essentially this ability to acquire and apply knowledge and skills and to adapt to new situations. Okay, the Encyclopedia Britannica, I think, eloquently describes it as the ability to learn from experience, to adapt to new situations, understand and handle abstract concepts, and to use knowledge to manipulate one's environment. So those are different components of intelligence. And when we now talk about artificial intelligence, it's really how does machines mimic human intelligence? So AI, think of it as a field of science or technology that allows machines to mimic human cognitive functions, such as learning and problem solving, and it does that by following algorithms and sets of rules. And even though we're talking about AI in healthcare now as a relatively new phenomenon, it's actually been around us for many years now. So you think about, Siri or your Google Voice, your Google Home at home, your Alexa, translating apps on your phone. The banks use credit card fraud technology to know whether someone's using your credit cards. Facial recognition is everywhere. All of these are forms of AI that have become mainstream. And so why are we talking about AI in healthcare? Why is this dramatic surge in AI technology in healthcare? Well, it's due to a convergence of factors that have come about in the last 5 to 10 years. So we've got this ready availability of multimodal data sets. So we've got lots of data sets related to demographic information, so where people live. We've got census data, for example. We've also got now clinical data in the form of electronic medical records. So we've just adopted the DHR from Epic, but they are becoming much more widespread. We have now genomic data sets. So we have the DNA of humans. So we've got whole genome sequencing. We've got research data sets and research registries, and we've got government data sets that allow us to do data linkage. That has occurred in parallel to increase computing ability. So our processing units have exploded in their capacity over, they sort of double every couple of years is the general rule of thumb. High speed, lower cost, and newer computational techniques have made us being able to increase exponentially our computing ability. At the same time that we have got a huge increase in storage capacity. You just have to think about your mobile phones and how many megabytes of storage it had a few years ago, and now it's measured in terabytes. Okay, so the storage capacity is increased, which is what you need for the massive data processing for artificial intelligence. So we've got physical servers, but now cloud computing, and that's all occurring at a lower cost. And sort of related to the data sets, we are all connected. All our devices are connected. Our light bulbs are connected to our phones, are connected to our computers, connected to our DHR. Many of our equipment, or much of the equipment we use in hospitals, so blood pressure machines, ECG machines, are all connected to the DHR, and particularly in the new building, in Building 5, that will be even more so. We've got this Internet of Things, which is, again, happening at the same time of all of these other factors. So this is probably the slides I know least about, so I'm going to quickly rush through them. Computational methods used in AI. Okay, so you hear about these computational techniques. I think it's important to at least know a little bit about them because they are quite different to the traditional methods of analysis that we have been taught over decades. So in terms of basic statistical methods, in terms of regression, in terms of how we normally allocate and categorize things. It's very different in AI. So we talk about things like machine learning. So machine learnings are algorithms that allow machines to learn and predict outcomes without being explicitly programmed to do a specific function. You input a whole bunch of data, it sees and learns patterns and relationships and can adapt rules from those large data sets. And based on further input and also feedback loops, it basically keeps on iteratively learning. So that's machine learning. Deep learning is a subset of machine learning. So it does a very similar sort of thing, except uses this concept of neural networks. So neural networks mimics the structure of the brain, where we've got layers of neurons that are interconnected. So these neural networks are multi-layered interconnected nodes that mimic neurons, and it allows the algorithms to learn unsupervised from unstructured and unlabeled data. Okay, so you don't have to tell the computer that this is a cat or this is something. It learns it itself through pattern recognition and data categorization. So that's machine learning and deep learning. Then there's this other type of AI or computational method used in AI called natural language processing. And that is where they use text or language as a form of data. And these techniques break down language and text into data points and tries to do thematic analysis, looking at structure and grammar and syntax to try and make sense of language, essentially. A subset of natural language processing is this thing called large language models, of which ChatGPT is the most well-known version. So this is not only breaking down language as data and understanding the associations between letters and text and words, but it then generates novel text or language, okay, to make it coherent and understandable to humans. And that's where these large language models are essentially natural language processing algorithms that are trained on vast amounts of data sets sourced from the internet. So articles, blogs, scientific papers, things like Wikipedia, digital books, digital encyclopedias. Basically, these algorithms are set loose on that resource. And essentially in a probabilistic sort of way, it makes association between words and predicts what the next word will be or set of words is. And an example of that is ChatGPT. Just very briefly, 2 slides to maybe put a little bit more meat on the bones in terms of machine learning and deep learning. So machine learning, and Daniel will talk a little bit about this in his what he's presenting in renal medicine. But essentially, you have a data set, so you collect information, or you've got information coming in from the various automated data sets that are coming in. You set that aside as a training and validation data set. You split them into training and validation. You put that input into an algorithm or a model which learns associations and patterns from that data. And once it's developed, it's getting more consistent results, then you can validate that to try and fine-tune the model. Once you're basically getting very consistent outputs from that model, then you test that against a test data set. Okay, so then you're comparing what the predicted outcomes are based on your historic data set or your validation data set against what the actual outcomes are in the test data set. And you can develop these receiver operator curves, so like the one down the bottom, which we're familiar with, and you get sensitivity and specificity analysis. You can say how sensitive the AI algorithm is. This is getting a little bit more abstract. So this is a deep learning model. And so this is what I was referring to about neural networks. So a neural network, essentially, it's a machine learning method where you're inputting data. The algorithm splits, say, for example, this image of a cat into multiple attributes, and it goes through various layers. And what's called so the input layer is the first layer in this neural network, and then you've got up to sometimes several hundred hidden layers, which are all come up one after each other, and then an output layer. And what happens is essentially each of the nodes is assigned a value and a weight or a coefficient. And as you pass from one layer to the next, you multiply the value times the coefficient. If it crosses a certain threshold, then you go to the next level. If it doesn't cross the threshold, it basically stops there. So through this sort of process, you get this probabilistic outcome at the end. For example, here, this neural network says that this image, which it doesn't know it's a cat, it just sees it as some digital data. It identifies through various attributes, digital attributes or data attributes, that it's 99% probable that this is a cat rather than a dog or some other thing. Daniel, don't laugh. This is probably a very basic understanding of what that is. Okay, in terms of now moving to more from a clinician point of view, so that's sort of AI, some of the theory, I guess, behind it and what is in the black box of AI. How do we use this in healthcare? So essentially anything that involves data and data storage and big data, there'll be an AI function or an AI model of care. So the main categories for AI at the moment are in diagnostics, clinical decision support, generative AI, where we're producing new text or producing novel text or communication. We might do modeling of disease progression or modeling of a system capacity. So modeling how the hospital is running, for example, the huge amounts of data that's coming in from multiple sources. What is the best way to allocate resource? And then in research and development, so for example, new molecule design, vaccine discovery, data mining and analytics. So those are the big sort of broad pots that exist for AI in healthcare. Just in the interest of time though, I'm just going to talk about the first one, which is about generative AI and AI as a clinical decision tool. And then the other speakers will be talking about some other aspects of AI that are currently available. So as you all know, we have Epic is our DHR. So Epic is an American company that is now provides the services or developed the DHR for lots of hospitals around the world. We've got a particular version of Epic or DHR. There are more advanced versions in the States where they've already integrated AI into the digital health record. So this is a 1-minute video showing what is possible coming to our Epic.
We've heard about generative AI and how it completely transformed the way you do business. But what you might not know is that the latest large language models, like GPT-4, are already built into that. Generative AI is here to use it through everyday tasks and spend more time on things that bring you meaning. And saving a little time here and there really adds up. For example, with AI, we can draft a response to a patient message, complete with a personal touch. Or nursing, simply over the vascular facet and draft a handoff, bringing up the care team to focus on communicating with each other. In the clinic, the system writes a concise summary of what's happened since the last visit, with links to the full details of the chart, helping providers get up to speed quickly as they move from room to room. This isn't science fiction. These features are already in use at health systems around the world. We're moving fast, with over 60 development projects in the works, and we're excited to explore more with you. Reach out to DFAT or emails to get started.
Okay, obviously that all comes with a massive but that all looks very interesting, and you can see if it's done in the right way, it could be very useful. Now, my next slide, I'm just going to do a bit of, Okay, so this is a bit of audience participation in this slide. So I get this in my inbox every week. So this is the New England Journal question of the week. And so I wanted to know, how does ChatGPT go if I gave it a clinical question and uploaded a picture of a rash to see whether it would be able to develop a differential diagnosis and recommend some tests. So does anyone, so medical students here or residents want to have a go at what this might be, a differential? for this elderly man with smoker, weight loss, weakness, scaly rash on the dorsum of his hands, slightly elevated ESR and an elevated CK. Dermatomyositis. Yeah, pretty confident with that? Not confident? Anyone else?
Smoker.
Yes.
Skin rash.
One of those? Yep. Okay, we're happy with that. Okay, well, so this is what ChatGPT came up with. So dermatomyositis, and gave us clinical features, some investigations, differential, and then some links to some of more authoritative websites. So this is like ChatGPT doesn't know any of this. It's just made this up. It's predicted the next word, but it comes up with a pretty coherent response. And this is a very passable answer in terms of what the diagnosis was. So I was impressed in terms of it answered this question correctly. But I did put in a couple of other questions that it didn't get quite right. So questions about patients who people, particularly return travellers with infectious diseases, seem to miss some of the context of the question and completely miss the boat. So it's still a bit patchy, but you can sort of see the potential. Just lastly, AI is a clinical decision tool. So this is what we currently do in hospitals. So a patient comes into hospital, we see a clinician, based on our training, reading of the history examination, investigations, we come up with a plan, we write it in the notes or the digital health record. That's what we're doing currently. With the conventional decision support systems, like for example, if you had your DHR calculated, the pneumonia severity score, or the pancreatitis score, or your ICU multi-organ dysfunction score. So currently this is happening where you can get a patient presents, the clinician enters data into the DHR, a algorithm calculates a score and then feeds that back to the clinician. Clinician integrates that in their head and then it's like, I'm going to use antibiotics, not use antibiotics, start oxygen, do this or do that. So that's a rule-based algorithm. The future is where potentially the algorithm or the AI in the DHR, for example, it not only spits out some sort of recommendation to the clinician, it could also request tests. You can say, I need more information. I'm going to order some more blood tests. I'm going to do an add-on test, or I'm going to re-screen that X-ray or relook at the X-ray. So it has this more of an internal loop. And then the future, which is something we need to think about closely, is whether the algorithm does it all. Does the assessment, does the history, takes the photo, does the pattern recognition, orders the tests, analyzes, orders the prescription, and follows up the patient. Obviously, that's the advanced version, and it's taking out the human touch, but that's what will be called a fully automated clinical system. So it's just useful in your mind, just thinking about where do we fit in currently. We're sort of between these two. Okay, I'm just going to introduce our first speaker. So this is a Perv guy from radiology. Thank you.
Hello, everyone. So my name's Apurv. I'm the clinical director of radiology here at the hospital. I don't really use AI much in the hospital, but I have used it in my personal life and some aspects of radiology. I'll relay a story. When I first joined radiology, there was one of the senior registrars, Simon Usher, who said to me, as your new job as a new registrar is to come up with a limerick for a normal chest X-ray report that we all can use. And I obviously never found one. But as soon as I heard ChatGPT is available, I asked ChatGPT to come up with a limerick for a normal chest X-ray. And I found it very fascinating. I'll just relay that really quickly, if you like. I just did it right there again. So in the chest X-ray clear, no shadows found, lungs and heart in health sound. No cause for alarm, just a radiologist charm, all normal image all around. So clearly, for me, AI is where a computer is actually able to do something better than a human can do. Radiology, we're not quite there yet, but I suspect at some stage in the future, radiology will get there, maybe in the next 100, 200 years when a medical tricorder will replace all our X-rays, CTs, and ultrasounds. So it will come eventually. So how can we actually use AI in radiology? There are probably two main components that it can assist us. In image interpretation, that's probably where we're furthest away from, but it certainly has started coming into workflow optimization for radiologists. So it can help to prioritize critical cases. I mean, a lot of the stuff that we do in terms of being able to voice dictate reports, being able to send them electronically, you know, that's not quite AI, it's more of a tool, but it is certainly something that has helped our work as radiologists. I'm too young to have ever had to put up a screen, voice dictate a report into a dictaphone, and then have it transcribed by a human transcriptionist, and then for me to authorize the report. So in terms of how technology, maybe not AI, has actually helped us, it has significantly improved my life and actually improved my productivity. So one area which was really good for AI, which a lot of the private providers are using, particularly the online Everlight and the IMED, who do a lot of online reporting, but they have these massive lists of reports, is that they actually use AI to help prioritize cases up the list. So they have tools which help them to identify intracranial hemorrhage, pulmonary embolism, and then they use that to bring that up to the top of the list so that the radiologist knows what is the most important next study for me to report. There are a lot of AI companies who are actually using a lot of that online information from these online providers, because they actually have access to a huge data set of a huge number of images. They're able to actually take that information and then look at the radiologist report and then use that machine learning, deep learning, to try and teach the AI exactly what did the radiologist end up seeing. I mean, we have been talking about AI in radiology replacing us for many years, but even basic things like nodule detection, breast detection, very little of that has actually come into our daily practice to actually optimize things. The couple of people who do some online reporting that I've spoken to have said that when the AI is sitting in the background, it actually slows them down because it keeps pointing out things which their brainstem has said there's nothing there, and then they start to second guess themselves. Oh, maybe there's something there. So a chest X-ray, which would normally take them 30 seconds or a minute to report, is now taking them a couple of minutes because they're making sure that the AI didn't pick up something that they did not realize. But they've never found an instance where the AI has picked up something that they didn't already recognize, but much more in the opposite direction where it overcalls a lot of things. Okay, so where do we use AI in the hospital? The main area that we do use AI is when we do our stroke workups. So anytime anyone presents for a stroke workup, they get their non-contrast CT brain and they get the CT angiogram. And there's a program called Rapid AI, which actually analyzes the images. So this is an example where it's basically used to pick up intracranial hemorrhage. So it points that out for use. It's not really used by us as radiologists because we look at the scans in a different way. We usually leave it for the clinicians to use. So the stroke team uses it much more frequently. And it's there to basically make decision-making a lot more rapid, as the name suggests. So they can make decisions much more early on before it takes maybe half an hour, 40 minutes for a radiologist to come and review it, because for them, time is brain. So it does more than just look at intracranial hemorrhage. It also looks at large vessel occlusion. That's the stuff that they can actually look at in terms of doing a thrombectomy on it. So this is this image here is a MIP image. It's basically showing that the left MCA has got a clot in it. None of the vessels are opacifying. So it'll actually tell us, hey, there's a suspected LVO. It'll even take the perfusion data that's associated with it, and it'll actually work out what is the core and what's the penumbra, and is it actually worth going on and treating it with a thrombectomy. And you can see that the computer actually spits out that there is a mismatched volume, and thrombectomy should be considered in these patients. So I'm not worried about my job. I'm probably not worried about if my kids become radiologists, whether they'll have a job, but AI will certainly help us to become more efficient in what we do, and allow us to probably report faster and quicker than what we are currently at the moment, but we're still a few years away. Okay, thank you.
It's superb. So I'd just like to invite Daniel Cristiati. He's a nephrologist, but also the PhD candidate at the John Curtin School, Medical Research. Sure.
Thanks for the opportunity presenting our research project. I believe everyone in the audience doesn't need me to remind them that CKD, chronic kidney disease, is associated with significant morbidity and mortality. And even amongst experienced nephrologists, progressions to end-stage kidney disease remains difficult to predict. And for us to start kidney replacement therapy, which is the only treatment available for survival, requires some planning, like for example, dialysis access creations, transplant workup, or even resource allocation for dialysis spot creation. So, and it's also undeniable that our chronic kidney disease patients, they are aging, and also they have high incidence of cardiovascular or non-cardiovascular mortality. So this is the formula of Cox proportional hazard. The majority of risk scores used in medicine relies on this formula here. And however, this approach can only use baseline data, meaning that it's static. The static predictive model will potentially miss or will not appreciate the valuable prognostic information derived from the longitudinal data of any predictors. Hence, in our project, we combine the landmarking approach and a machine learning algorithm called random survival forest. Let me give you a snapshot of what the method is all about. So on the left, that's the image of the landmarking approach. So with landmarking approach, we create multiple risk groups, and we try to predict. We have like what we call as a prediction horizon for the next 5 years. With each multiple risk groups comprised of subjects who haven't experienced the outcome. And creating these multiple risk groups allow us to incorporate longitudinal data. The random survival forest, which is the image on the right, is based on a machine learning algorithm, a popular one called random forest. Basically, it's utilizing multiple decision trees to predict outcome. And in our case, it's end-stage kidney disease with death as a competing risk. So we train our model using 5,000 patients who attended a kidney clinic at Canberra Hospital, and the model has been externally validated on 8,000 plus patients from our WA collaborators. This is one of the results. So this plot shows the C statistic. So C statistic is a performance metrics showing the discrimination's capability of any survival analysis model. And the box plot in blue is ours, the red is the external data. On the y-axis, we have the C statistics, the higher the better. And on the x-axis is all the landmark time. So roughly our model perform about 85% concordance index. And the performance it's preserved when we evaluate our model on the external cohort. So what does it look like? Those results probably looks flashy, but it's probably not applicable. This is the output. Let's say I have a patient. This is not a hypothetical patient. This is an actual patient. He's 64. I don't know whether he or she. 62 years old patient presented, and this is all the data accumulated from his kidney functions, hemoglobin, serum albumin, serum chloride, and the glucose. So the plot on the left is the graph of the value of the biomarkers, and utilizing 3 years worth of data, the machine predicts. So the plot on the right shows the cumulative incidence function or the hazard risk when there is a competing event. The blue one indicates the risk of developing end-stage kidney disease. And obviously, in this case, it rises dramatically from 15 to 30% between maybe 5.2 years in the future. And surprisingly, he develops that event during those time period as well. A similar patient, 64, And in this case, his risk of dying is actually outweighs the risk of end-stage kidney disease. So where are we sitting? So we are planning to incorporate this into our EPIC. And so something that a tool that our clinicians can use to help them to think and maybe to start planning for the patients what needs to be done. So shifting the gear to a different project. This is a collaborative project with the anatomical pathology led by Dr. Mitali Fadia. And I also have medical students helping me in these projects in the room as well. So glomerulonephritis and vasculitis remains one of the most common cause of end-stage kidney disease. And the diagnosis, treatment response, and prognosis relies heavily on kidney biopsy. And that makes medical kidney biopsy interpretations a challenging diagnostic tool. This is a digitized kidney biopsy slides in low magnifications. We could appreciate how complex, how rich the informations in one slides. And we as humans, we have limitations to extract or even interpret the information. All that we could do is provide a summary or qualitative report of what the biopsy actually shows. So to be able to extract the information effectively, we need to identify, we need to segment each individual structures. That's the capability known as the instance segmentations. Like the pictures, we try to identify the objects in that image. We try to identify each individual of them and put a marker to delineate them. And this is what our model is doing right now. So unfortunately, I can't disclose more information because we are seeking intellectual property applications for this. But I'm expecting there will be more information that I can share in the near future.
All right, they look very mysterious there, finishing, Daniel, but we'll hear more, no doubt. Vipul, do you want to come up? So Associate Professor Vipul Agarwal is the Director of Gastro and Hepatology, and we'll talk about AI and endoscopy.
It's just on here. Oh, yeah. Yeah, thanks, Ashwin. So I'm going to talk about AI and endoscopy and change tack a little bit because as far as endoscopy is concerned, AI is already here. And when I say here, I don't mean Canberra Hospital. We barely have a endoscopy suite, so I won't talk about a Canberra Hospital. But certainly within Canberra, in the private setup, we do have artificial intelligence available right now that we are currently utilizing. So there's, but obviously there's a long way to go. So I've actually sent about 50 slides, which have been cut down to 8. So this could be a talk on its own, but I'm going to try and do this in 5 minutes. So just to give a flavor of what's available right now, I suppose. So one of the key quality indicators, if you like, of colonoscopy, and I'm merely talking about colonoscopy, or the applications of AI within gastroenterology are actually now quite widespread. But one of the key quality indicator is polyp detection, or as we call adenoma detection rate. And that is, every endoscopist has to have a minimum adenoma detection rate. That is, if they want to be certified as a colonoscopist. So one of the goal of what we call CAD-CADI, or computer-aided polyp detection, is to improve our adenoma detection rates by picking up polyps that may not have been visualized by the endoscopist real time. It also acts as a second pair of eyes, which currently, prior to AIs, usually our nursing staff or an assistant in the room or a registrar who, you have an extra pair of eyes, you're focusing on something and they can have a look and pick up polyps or other abnormalities, which we may not have seen. And essentially what it is a real-time highlighting, using a bounding box. So you have this green box or red box. You can have a red box too, but it's usually green, which kind of just, sort of goes in and out, and it or sort of, makes you realize that there's something out there. And then you eventually go and focus closer and see if there's a polyp or not. There are some false positives, but it's pretty good. So it's interesting to see that the first randomized controlled trial was only published in 2019, so it's fairly recent. But there's been this whole influx of research and randomized controlled trials, and they're close to about 20 trials, RCTs, which have already been published. And if you look at that, if you look at what they show is that there is an adenoma detection rate, increase in adenoma detection rate of 10 to 12%, which is quite significant. If you look at any advancement in endoscopy in terms of adenoma detection rate, nothing is achieved at a rate that high, be it bowel preparation or other image enhanced modalities that we have. And so also the reduction in adenoma miss rate. But it's important to point out that the majority of increase in adenoma detection rate was in diminutive adenomas. And what that means is they are smaller than 5 millimeters, and we're still not sure what the clinical relevance of that is. So even though statistically and in terms of number and percentage, it increases, whether or not that will make a difference in terms of whatever your other goal is, cancer reduction and other things, is still to be determined. So we talked about a bit of that. So yeah, I mean, so theoretically, a 10% increase in an adenoma detection rate would reduce interval cancer by up to 50%. But I think what's again important is what sort of adenomas are we talking about? So this is just an example. I don't know how well or it projects or doesn't project, but this is that green box that you say, and it sort of goes in and out, flashes out. And if you look at it out there, it's not as visible, but when you then get closer and use enhanced imaging, you can see a well-defined traditional tubular adenoma out there, which was picked up by AI. Probably would have been picked up by an expert endoscopist, but the AI does help. So is it all good? And I think it's also important to highlight, when you look at those 20 randomized controlled trials, one, they all come from expert centers. And if you really, dig deep, if you listen to any of their presentations, every single lead author in that has a conflict of interest to some degree. And I'm not saying that the data is not accurate, but there is this whole thing, all of those trials come from centers where the AI machines have been put in by various companies. But what happens in real life, or more sort of real life studies, if you want to. So one of the key drawbacks which we've used, and we see this on a daily basis, is this inability to pick up these kind of polyps. And these are different from the traditional tubular adenomas, which AI is pretty good at picking, but these are what we call sessile serrated lesions, sessile serrated polyps. And they have a different pathway towards cancer. And the currently commercially available AI systems are not good at picking these up unless you really point your scope to it. But if you're pointing your scope to it, that means you already found it before the AI helps you to get it. So that is a limitation. And then there's been a few real world studies done. There's 2 observational studies, and there were 2 randomized controlled trials. And none of them showed a significant difference in terms of your adenoma detection rate between AI and your standard endoscopy. So I think that's where you've just got to be a little bit careful in terms of how we utilize it, because in some ways the major impact that I feel is when do you introduce it to your trainees? When should they start using AI? Is going to be an interesting question. So what is the current state of play in terms of using computer-assisted detection of polyps? There are multiple platforms and algorithms for this. And we do feel that there's been a very rapid push towards commercialization. So there's a lot of competition between the different device manufacturing companies, and they all want to be the first one to put it in and integrate it into their processes. So that's what's happened, and they've marketed it really well. So it is available. And we are using it, but there's no head-to-head comparison. There's no benchmarking, and there's all this, black box proprietary algorithms which are not easily available. If you really want to make the system work, then everyone has to bring all the data sets and everything together to really improve that. So I think the benefits are probably more likely to be sort of operator dependent, and a hybrid model where the AI provides you part of the thing, but it's how you integrate as an operator with the AI and not relying just one or the other. So I think it's not one or the other. It's a hybrid thing between the two of them. And I think that's the last one, right? Right. Yeah. So like I said, I mean, my main concern is, when do we get the trainees, advanced trainees? Should they know how to pick up polyps before they see AI? Otherwise, all they're going to be looking for is those green boxes, and they're going to miss that thing. So yeah.
Thanks, Vipul. So we're just nearly at the end of the meeting. So I've just got two more slides. Just one about cautionary tales with AI. So it's a new technology, it's advancing fast. There's obviously all sorts of pushes to integrate AI into our work, but we just need to understand exactly what we're doing and why. Just be careful that there are inaccuracies that AI can introduce. So rubbish in, rubbish out. We're already seeing it with DHR, what I call sort of cut and paste-itis, where everyone's just cutting and pasting what was previously written by someone else into the next document, and it gets into a discharge summary, which appears in the next admission. And if we're starting to use that data as the basis for planning patients' care and diagnosis, you're going to get generational mistakes, legacy mistakes. Understand that these large language models can hallucinate, is the term. So basically, just make stuff up, inaccurate or incorrect information. Sounds really impressive, and it says it confidently, but it's just it's not real. So just be careful. Evolving technology that is little understood by clinicians. It is far removed from our usual training for how we review evidence-based medicine. It's truly black box technology. The validation methods may not be published or easily accessible, how they actually got to a particular point in terms of a recommendation or how it's making its decisions. There are sources of bias in the training data sets that will be baked into the AI model. So there may be an under or misrepresentation of minority groups or genders. They may be using, the data might be coming from international data sets, or really large data sets, which don't work for the local population. An example of this was there was a company that made a soap dispenser where you had to wave your hand in front of the sensor. And it turned out it worked fine, except it didn't detect black hands. It only was trained with people with Caucasian skin. It was inadvertent, but you can sort of see how these things can happen. And then there's the big one is data security and privacy. It's unclear where this data is stored, particularly if it's Google or Microsoft or someone's owning the AI software, and under what regulations, and what is going to happen with that personal and health information that can be kept and used by the owners of the tech. And just lastly, I'll refer to the Safer Victoria Health Service Advisory that came out in the middle of last year when there was all this excitement about ChatGPT. So it makes some very clear recommendations about how you can and can't use particularly the generative AIs in a clinical setting. Do not enter patients' data, like their URN, any individual identifiers into ChatGPT or Bing or any of those other chat boxes. We don't know the security. And also, these are all governed by TGA regulation. If you're using a technology to make a clinical decision, it is actually under TGA regulatory device, and none of these chat boxes or generative AI technologies are actually regulated have been approved by TGA. Okay, so just be aware, medico-legally, if you make a decision based on what ChatGPT says, then you may be in trouble. Yes. Just lastly, I like this as a slide I stole from Vipul's 50 slides he sent me. And this is true for AI, but it's true for any new technology. There's often a lot of excitement when a new technology comes online, and then you get this sort of peak of inflated expectations, and then all you see is all the problems with the AI, and you think, oh, it's hopeless, this is the worst thing ever. And then you get to this sort of steady state where you make sense of it and you see the utility of the technology. And I think with AI, we're sort of here, still in the upslope, thinking it's going to do great things and be amazing. But we're going to hit a phase where we start seeing the problems, but we shouldn't throw the baby out with the bathwater. We need to see how do we actually integrate this in a positive and safe way. So take-home messages. AI technology is transforming all facets of healthcare with the potential to achieve sort of the four aims of healthcare. So these are the things that we always like to do: increase access to healthcare, lower costs, improve patient experience, and make the health workforce more efficient and retain us in the workforce. There are many current examples of AI used locally, especially in diagnostics, and many in the pipeline. Just know that Epic DHR may have some things that are coming to us in the next year or two. And the pace of AI development and rollout is bewildering. We need to be, I think meetings like this could be useful, and I'd be interested to hear your thoughts, but we need to have an understanding of what it is And we need to also have the ability to regulate and police its use. And there are really good reasons for any new technology, but particularly this, to take a cautionary approach. Thanks, everyone. Thanks to the panel as well for the other speakers. I really appreciate it. Short notice that they came up. Thank you. Any questions? Nicole.
I'm not sure if I'm supportive, but I was actually just wondering, I don't want that analysis of files over adenoma detection. Are they actually collecting long-term data afterwards to follow these patients up and follow up the detection of actual colorectal cancers in both arms? Because as you said, it doesn't matter if you're picking up a 2 millimetre adenoma if it's not.
Well, yeah, I think that's a key question, but we don't have those answers. One, because the file is very recent. But in the long data, so the first file was published in 2019, and the last one been published earlier this year. None of them have stated whether or not they're going to follow them up. What that is because as the study design is considered only level adenoma detection way. But that is the key question, and I think it'll come. But more importantly, I think I've only given a flavor in stroke and colonoscopy, but it's enough GI and everything else. But the next step, which is emerging and is already out there, is not detection, but actually diagnosis. So in terms of histological diagnosis, is this an adenoma? Is this a benign lesion? Is it got some mucosal invasion or not? Is this a cancer? And I think that's going to be the real turning point in terms of this utilization. So I think it's the selling point for one competitor to some degree. I'm not saying it's bad, it's cool, but I use it half the time. It's irritating at times, just swimming spots and all that's not there. And so I think it's got a role there. If we have this maybe 12 months time, there'll be a lot more information.
Thanks, Nicole. Any other questions? We've gone a little bit over time, but happy to take questions for the group outside if there are any. But I think if we could just join me in thanking our presenters again. It's fantastic.